Well, this is a very compelling story. I came to this small town in Tennessee in 1985 expecting to see very little HIV infection. And there I was in 1989 following almost 100 patients, which was 100-fold more than anyone would have expected for a town that size. And the sort of story behind how that happened and the story of the transformation I underwent in terms of the voyage I took coming out at the other end, changed, so to speak, was a compelling one, and I felt that I had to try and capture that. I think Johnson City is in many ways identical to almost any small town you could care to mention. Johnson City is a quintessential small town, 50,000 people, surrounded by mountains, a sense of being insulated from everything that we think of in a big city, drive-by shootings and subway vigilantism, and especially AIDS. And I think that what I describe in this book, this phenomenon of an explosion of HIV there, is exactly what's happening in other towns. And it's not that this is a hotbed of sexual activity. Rather, the disease seems to have brought to our attention this complicated pattern of migration that's been going on for some time, but that AIDS has brought to the forefront. Young men growing up in small towns, leaving the towns for the same reasons all of us leave small towns, jobs, education, but in their case because they were gay. And they left the small towns and went to places like New York, Seattle, Washington, Los Angeles. And even as they sort of became themselves and lived the lifestyle they wanted to, tragically they also acquired the HIV infection. And their coming back was precipitated by loss of a job, loss of a lover. And there I was seeing them on their return. But really this was the completion of an elaborate migration that had begun many years before I ever knew them. Well, I think part of it is that I was very much an outsider looking to fit in. I was born in Africa and educated in Africa and India, then came to this country, and I was always trying to find this place that I could sort of call my own, hence the title of the book, My Own Country. And I kept sort of trying to learn all the rituals of Monday night football and possum pie and whatever it took to blend in. But it became very apparent to me early on as I began to see more and more AIDS patients that I really didn't have anything I could offer in terms of cure. And I began to understand the distinction between curing and healing. Even when you can't bring about a cure, there is an important role for a physician, perhaps a more traditional role, that is of being at the bedside, going into the house. And to the degree that I had nothing else to offer, I found myself stepping across this threshold and entering their lives and learning about the family, learning about how they lived. I'm intensely curious by nature, but I think some of that is simply clinical curiosity. When you see a patient, you take a history. Well, a history is nothing but a story. And as I teach medicine now in a medical college, I often find that when I'm called in to see a case, if I have something to offer, it's often not from some extra knowledge of mine or something I discover at the bedside. It's usually because I push the history some more and get some element in the story that gives a real clue to what's going on. So I think part of it was curiosity, part of it was this outsider looking in and curious to know how the world worked in Johnson City. Well, there was this magical moment when I would open the clinic door. It's still a magical moment. When it happens now, I'm still, I'm still excited about it because you know that the person you set eyes on, it's almost like the beginning of a story. You know that you're going to keep seeing them, and you know how the story is going to end for the most part. They're going to get sicker and die. But I always had the sense that as I opened the door and I stepped in, as they set eyes on me, there must have been an element of relief on their part to know that this person who was going to take care of them with this awful infection was perhaps someone who wouldn't judge them, was someone who didn't have the face of their elders or someone they would see at church or in the Kiwanis Park and so on. More than that, I even had people like the preacher I mentioned in the book who comes in for sexually transmitted infection. I had the sense that he almost felt that not only would I not judge him, but as an outsider, I had no right to judge him, which is what brought him back again and again. I think that I've always said that taking care of HIV in a small town actually feels like you're taking care of two diseases. There's the virus, and then there's this metaphor of shame and guilt and homosexuality that travels with the virus, and the two are inseparable. The few patients I've had who committed suicide committed suicide at the moment they were told they had HIV. And I felt it wasn't the virus that killed them, it was this metaphor of shame and secrecy that they couldn't control. And it seemed to spill over onto me. I became the head of this large secret society, and we moved through the town, and we had names and disguises, so to speak, and there was a sense that I wanted to break free of this and announce to the town, look, we have a problem, let's deal with it openly. But I think it's part of the phenomenon of small-town America that for some time to come, this disease will always have this huge stigma of shame and guilt. Whereas I'm impressed when I see gay men on TV talking about AIDS and talking about their homosexuality. That does not seem to be the issue. They seem to have gotten beyond the issue of shame and guilt, which was so big in the early 80s. I don't know, I don't think so. In the context of this book, Good Morning America came to the town, and we filmed some of my former patients, and many of them requested anonymity, requested their features be concealed. And their reasons are very clear. One lady called Vicky McRae in the book, she says how in her last community, people were harassing her daughter on the school bus, saying AIDS, AIDS, AIDS. And she finally stopped the school bus and said, look, to the driver, she said, look, my husband's in there dying of AIDS. Do you want me to get someone to sit with him so I should ride the school bus and protect my daughter, or are you going to take care of it? Well, he took care of it, but now she's moved to another community and she doesn't want to go through that again. And I don't think it's a struggle that in a big city is as acute, because there's so much awareness in the big cities, I feel. No, I don't regret not keeping a distance. In fact, I think the whole business of the distinction between healing and curing has to do with this sense of distance. If I can give you an analogy, at the turn of the century, when a Western physician saw someone with pneumonia, they would examine the patient carefully, and they had all these names for all the sounds and findings on the lung exam. And then they would begin their treatment, which was inhalations and hot fomentations, largely ineffective things. At the very same time, the Native American physician would also see the patient and had his or her own vision of what this was, and they would begin their ritual of chanting and whatever. Well, when penicillin came along, a magic drug, I think the Western physician gave the penicillin and, metaphorically speaking, just stepped away from the bedside. Whereas the Native American physician gave the penicillin but continued the chanting and the ritual, recognizing the need for both cure and healing. And I think that as Western physicians, and I'm really blaming myself, I came to this country caught up in the conceit of Western technology. But I think as Western physicians, we stood back for the longest time and said, this is the threshold, this is our technology, we offer cure, and we were unwilling to really step forward too far. I don't regret having sort of stepped in, and you're right, I left eventually because of a form of burnout perhaps. But I think more than that, there was this moment when the hospital administrator called me to his office and said, do you think we're going to see more AIDS in years to come? And I said, sure, I mean, this is a disease that's increasing everywhere. Then he said, well, do you think that if you were not here, would we still see this much AIDS? And that was a moment of great disillusionment for me, because I had come to this town and had the sense that I had really given a lot to it and was looking to call it home. And to have this said to me made me suddenly feel that, I needed a break. And I have a self-fulfilling prophecy. I think many of us in AIDS care wind up leaving a certain setting for another setting, always in AIDS care, just because I think we need a new beginning, a new set of faces. We need to go to a town and have an identity different from that of being the AIDS doctor. But I don't see myself leaving it. We have nurses, for example, who have worked with me and then have gone on to work in some other doctor's office in another specialty. And they'll call me back and say, this is so boring here. And it strikes me that there is no job description that encompasses people who work in AIDS. It really would overtake any job description, because you're always doing things extraneous to the traditional definitions of your job. But in a way, that's the very thing that keeps me in it. As much as I regret losing my patients, especially the ones I become very close to, at another level, I feel like it's life lived very intensely, life lived at the edge. I don't think I struggle that much for meaning in my own life, because I feel like the work I do, in a sense, is my meaning, if that makes sense. Thank you.